set? Yeah. Okay. Well, good afternoon. We start the symposium, and first of all, I would like to honor for me to share the chairman with Professor Van Gulik, and then we start with the first presentation. The speaker is Dr. Asmund Friedland from Norway, and he presents the case of the posthepatic liver failure.
Thank you. Thank you so much. Talking about an honor, it's a real honor to be here with two distinguished professors like you. Ladies and gentlemen, I want to present case report, actually one long case report and one short. I have these disclosures. But my first question is, why do we always get a complication just the week before we go to a congress? How many here, hands up, have thought about a patient today with a possible complication back home? Hands up. Yeah, not bad. How many here currently worry about the liver function of a patient back home? So as an old liver surgeon in Norway said, this is why HPB surgeons should earn a lot of money, because we constantly worry. This is my office mate, Bård. The week before we went to New York, he did 2 CLAT-scans and a hepatoblastoma in a 7-month baby. He came a little bit early to go for a ride. On the Tuesday, one of the CLAT-scans, 3A anosmosis to 2 bile ducts, really small. And on Friday, the day before his flight, the bilirubin was 107. I think that translates into 6.2 in US. So it's like a liver failure on his way up. And flight is Saturday morning. I was on call, so we'll just have Bård with us through this talk. Now to the main case, which is some years ago and was really a life-changing experience for me as a young liver surgeon. This is a male born 1950. He had a distal rectal cancer in situ, locally advanced. Previously, he was treated for lung cancer with an operation, and he was cured. But he had huge liver mets. But he got chemo and had a stable disease. I think now we'll see the scan. Yeah, you see, huge liver disease, and we were really in doubt what to do with this guy. His FLR segments 1 to 3 was 443 milliliters, a big guy, so that was 22%. We did a PV of the right. We did not embolize segment 4 because of a tumor in the whole segment. 6 weeks later, FLR was 655. That's 32%. KGR is just about okay. FLR is 32%, a little bit old, a little bit comorbid. We were really, really in doubt about this one. So on the pro side, he's got resectable disease. FLR is on paper good enough. Honestly, most of the resected part is tumor. He's got a network, he's only 68 years old, he's got the spirit, and he really wanted surgery. This guy had escaped cancer before. He had a lung surgery for cancer before. He was cured. Said, I'm willing to take the risk. I said, this might not go good, I said. And also the tumor is big. He will die from this tumor if it progresses. The bad thing, primary was in situ. KGR was not too impressive. Maybe his overall prognosis was quite poor. High risk, and at least in our numbers, our males in that age are the worst case, the worst patients. They do worse. But we went for it. So we did the right trisectorectomy. It was in my learning curve. The chief of surgery was assisting me. Everything went fine. Huge specimen, 1.2 liters of blood loss. So it was a little bit on the wet side, and reconstituted the falciform ligament to support the liver. After the long operation, I told the patient's daughter, who was a nurse, it went well, but he's going to need a little luck. So on the night of the surgery, the nurses in the intensive care, they complained every time he's on the right side, he's getting hypotension, and it goes on. And then at 4 o'clock we get the labs, and you see the AST and ALT is really, really high. Lactate was 6. That's when they called the surgeon. We did the CT scan, lactate rising. The CT was ready around 6 o'clock, and it looks like this. You know where this is heading. So the whole liver is completely twisted, and there's no outflow. We went to emergency surgery. All the sutures on the falciform broke. We didn't leave the colon up there to support it. And it was resutured, and we took the round ligament, sutured up in the fascia. And could you start the video here, please? We see now that postoperatively the liver is fine with inflow and outflow. So the first take-home message, there are 2 take-home messages in this case. The first is to suture the falciform properly and make sure that the liver has support. And if in doubt, suture the round ligament up to the fascia. What happened is that the patient initially wakes up, and the first week he was in quite good shape. He was in the ICU, then back to the ward. He was walking around, eating, visited by friends and family, but his liver actually deteriorated. And this is the bilirubin curve. There was not much we could do about it. I went to a congress. I had to go somewhere. I was on the telephone with her daughter every day, and when we came back home, she was complaining that I struggled to communicate with my daughter, so the patient's granddaughter. We set up a meeting, and I did try to explain that we're not sure if this liver is going to heal. We're really on the tightrope at the moment. And this bright-eyed 16-year-old girl said, "Why don't you just tell me that he might die?" So that's my second take-home message from this case is I should have used the word death, and I started to do that after that, preoperatively in the case of complication. Just say it. The patient knows there's a risk, and the relatives also should know that that's the potential outcome. So he died about 3 to 4 weeks after the operation, peacefully and okay, but a bad case for us. What about Bård's patient? On Saturday, just before you boarded, I called you, and the bilirubin was turning down, and it's looking better. The patient is still in hospital. There are some issues, but the liver seems to be working. So that's my case presentation. This is the Oslo team and our National Hospital in Oslo, where we're working. Thank you for the attention.
At the end.
Yes, yes, yes.
Okay. A second.
Yes, thank you. Yeah, thank you very much for this nice. Nice. It's it really sets the
Nice
stage.
for us, not for you.
It sets the stage for the problem we are talking about this afternoon, and I think there's a third take-home message, and that is never do a large case when you leave the continent for a congress. That's one thing that's for sure. Okay, I think there are a lot of questions, I'm sure, about this case, what you should have done or could have done, but we decided that we'll have all the questions at the discussion at the end of the presentation. So we'll first have the other 4 and then continue with discussion. So the second speaker is Dr. Sudeep from India. And he will talk about preoperative assessment of future liver remnant function and volume. Dr. Sudeep.
I thank the scientific committee of the IHPBA for this opportunity to discuss preoperative assessment of the future liver remnant. I have nothing to declare. We know the success of liver resection depends on leaving an adequate quantity of well-vascularized and drained liver, which is of reasonable quality. The poorer the quality of the liver, the more we need to leave behind. Measuring liver volume has not been simpler with DICOM images. Proprietary software is available with almost each CT manufacturer, and we can also do it at home in a simple manual manner using software such as Osirix or Horos for the Mac and the DICOM images on CD or from PACS. So this is a screenshot of the desktop. The area of the future liver remnant is marked out by seeing the pixels at the edges in the portal venous phase using the polygon tool. The area of each of these cuts is calculated. Here you can see the area is 57 square centimeters. Up and down, and the intermittent areas are filled up by the software itself, maybe slightly crude, so requiring a little adjustment here. Then the total volume is calculated by multiplying the area by the thickness of each cut to give you a volume, which in this case approximates 651 cubic centimeters. Similarly, the total liver volume can be calculated, as can be the volume of the tumor, and we can therefore get a liver remnant percentage as the residual volume divided by the total liver volume minus the tumor volume. 37% is far more than adequate for a normal functioning liver, where we might even have a volume as low as 20%, which is acceptable. For a cirrhotic liver, we would like to have a 40% liver residual volume. And for a liver which is steatotic or fibrotic, we might accept a volume of 30%. Therefore, an uneventful resection can easily be carried out. We know that this software is time efficient and it is accurate compared to even proprietary software. A simpler way of doing it by using proprietary software such as this, which is the Miriam software, where we just click and mark the vessels, and the tumor can be pixels are identified by this purple color. Tan marks the liver, and we can see a 3D reconstruction of all this within the patient. And we can even mark the venous anatomy. We can see the areas of segmental drainage, portal, as well as venous, so that we know that with our precise plane of resection, how much of the liver is going to be well vascularized, as well as the volume of the liver that we are leaving behind. There are many such proprietary software available. This is the Hepatic VCAR GE, IntelliSpace Philip, TerraRecon, and this is Liver Vision, which is made by 2 Turkish surgeons. So many of these are available in the market, and all of these are very effective. Comparing the 2D manual versus this 2D and 3D automated as well as semi-automated, we know that reproducibility is across the board. Time is much saved using the automated software, while for complex implementation, the manual still remains better and the manual is clearly robust. Automated is not without its problems, as can be seen in these images where the heart has been included, the kidney has been included, even in this case, collections have been included, as well as fat around the liver. So it is not without its problems, and there is an ever ongoing better learning algorithm. Which is better, CT or MRI? We know that CT is commoner, it's part of routine evaluation, has a very low acquisition time. The spatial resolution is excellent, and the Hounsfield units are standardized across each and every CT machine. MRI, on the other hand, is not standardized, but involves no radiation. The biliary anatomy can be seen. The multiple contrast media where we can take advantage of this. MRI is not without its artifacts. You can see motion artifacts here because the acquisition time is longer, ghosting by the gallbladder, ghosting of the aorta within, and fat within the liver, giving you an artificial low volume in this case. Parenchymal quality assessment is a big advantage of MRI, and a protein density fraction can estimate the content or percentage of fatty liver. And iron-corrected T1 mapping, or the CT1, can tell us the degree of fibrosis with some accuracy. When this is combined with volumetry, such as in this diagram, which is from the Hepatica study group, we can see that using neural network learning software, we can have a virtual surgery platform where multiple metastasis resections can be planned, and this can be overlaid on the background quality of liver, giving an idea of whether there is good healthy liver left behind or unhealthy liver. So even smaller resections in Leaving a large volume of unhealthy liver can be predicted by this software, and this is probably the future to tell us whether these resections in colorectal metastasis would lead to liver failure or not. Coming to the functions, we know that liver function tests and crude assessments such as the child score or MEL score are not really accurate in telling us who will sustain liver resections. Clearly, child's high B and C, high MELs are not at all suitable for liver resections, but for low grades of child and MEL, we really do not have the discrimination with these crude tests. Portal hypertension has been suggested by the BCLC group as being a contraindication for liver resection, and this can be measured by HVPG or surrogate markers such as varices or platelets. They have performed a meta-analysis, so this is by the same group, to tell you that the survival as well as decompensation is really much worse if there's portal hypertension, and across the modality which is used, whether it is HVPG, portal venous pressure, or surrogate markers, which have been used in this group of patients. However, this is not universally accepted. The EASL admits that monosegmentectomies are perfectly feasible in patients who are cirrhotic, and the East uses a different approach. So indocyanine green, which is an albumin-bound dye with uniform blood distribution, which has an exclusive unconjugated liver clearance and can be used to predict global liver function by seeing the retention at 15 minutes or the plasma disappearance rate. It can be easily measured by pulse spectrometry on the finger or by looking at blood levels. And this is the classic algorithm from Makuchi et al. This is from the Seminars in Surgical Oncology 1993, where in the absence of ascites and a normal bilirubin, using the ICG-15, depending on the percentage of retention, you can determine whether very major liver resections can be done or you're down to limited resections or enucleation. There are several validating studies of this from the East, and even from the West. This is a large series of almost 700 cases using the retention as well as those with plasma disappearing time to distinguish between those who have a normal liver function and decompensation after surgery. There are certain confounders to ICG. If there's intrahepatic shunting, we might get a false value. A very small percentage of patients are intolerant to ICG. And we must remember that it is a test of global liver function and not just of the segment that we are leaving behind. Scintigraphy has been used, and this is the technetium-99 mebrofenin scan, where we measure the ROI on the liver and the heart to calculate a function as a percentage uptake per minute, and we adjust it for body surface area. And we have cutoff values depending on the paper that we read, 2.3 or 2.69, depending on the literature. And values of uptake worse than this would predict poor liver function and a higher chance of failure. Obviously, this mebrofenin scan cannot be used in obstructive jaundice, so patients with high cholangiocarcinoma, unless they're well drained, this is not an appropriate marker. And comparing mebrofenin clearance with ICG clearance, we can see that there is very good correlation. Another scintigraphy with GSA, which is galactosyl human serum albumin, you can calculate a clearance index depending on the differential clearance from the heart. And we can calculate a receptor index depending on the uptake of the liver. And this receptor index very clearly correlates with morbidity in a group of patients with cirrhosis undergoing liver resection. A differential liver function with a SPECT overlay on the anatomy of the receptors can therefore calculate a percentage of what is the actual retention of galactosyl human serum albumin, and will give you the selective function of the future liver remnant. So this can be a differential liver function test. We must understand that whatever test we use, whether it's ICG or it is a volumetry, predictions will fail unless we are performing precise surgery with controlled blood loss. So in summary, DICOM CT volumetry is standard. ICG-15 is very well established for cirrhotics. MR-based software would, with liver quality, would be useful post-chemotherapy. Scintigraphy is a useful adjunct, and imaging is getting better, and stronger computation are giving us better automated tools. So we must remove the liver with care and not be too greedy, depending on the quality of residual liver. Thank you.
Thank you very much, Dr. Sudeep. We'll take questions in the last part of this session. So please, the next speaker.
Thank you. Well, the next speaker is Professor Sean Clary. She is from Rochester, United States. Sean.
Thank you, Octavio. All right. Thank you, everyone, for sticking it out until this point. Thank you to the session chairs as well as to the scientific committee for asking me to give this talk. So I think the issue has been clearly outlined by Asmund and our previous speaker. So again, it is something that's top of mind for all of us. Here are my disclosures. And again, I think we have a long-standing appreciation for everyone in this room of the importance of the liver parenchyma. It's out there in our guidelines. I think we spend a lot of time thinking about it. And really, the ability to modulate the future liver remnant has probably given us all a little bit of job security and extra work to do, because this has really allowed us to expand the indications for hepatic resection in multiple diseases, including this one, such as colorectal cancer. I think the case that Asmund displayed showed many of these important points about not just evaluating, but protecting and almost coddling the remnant liver to make sure that we are giving it its optimal opportunity to hypertrophy. And obviously, the important issues have been listed, including sepsis and intraoperative blood loss that are a little bit less well studied. But this really came, the appreciation and the science of the remnant liver, I think, really came out of the transplantation literature. These are early studies showing the graft weight ratio, demonstrating significant differences once the graft weight ratio dropped below 40%. And it's very important, I think, also we learned from the transplant literature that simple assessments of size are probably not sufficient. And I can't understate the importance that we have at our center in adjusting this for total body weight. And that, because as you can see, I live surrounded by cornfields, and you can see in the x-ray on the right-hand side the dangers of highly processed corn syrup. We are not only, obviously, I think, talking as well about the size of the liver, but I think we're going to see significant improvements in actually assessing hepatic function directly. The previous talk did this very well. I think one of the challenges is actually being able to assess the differential function between the future remnant liver and the global liver function. And so I think this is an example of using, for instance, MR-based hepatobiliary contrast agents to actually assess segmental function. And I think that this is coming to us in the near future. So we've noticed that and again, we've been able to take the transplantation literature and apply it to resection. These are pretty startling differences. We can see the future liver remnant of 20% as being a significant predictor of death after liver resection. And certainly, I think we are understanding that probably those early literature that suggested 20% was a little bit generous, and particularly as we see a rise in liver disease and fatty liver disease, we can see still outcomes, poor outcomes in liver remnants in the 20 to 30% range that are going to be extremely important as we assess patients for surgery. So really, I think without going through all of this, boiling down, this is kind of the algorithm that I will use, that really there are probably very few normal livers out there, particularly for our patients exposed to systemic therapy, but also our obesity epidemic, really looking for future liver remnants greater than 30% or even greater than 40% in patients with cirrhosis. And I think this is all pretty well established and appreciated by members of our community. And of course, the problem is that these insufficient liver volumes are a problem. When you look at population-based studies of the volumes of the right and left liver, we can see that the left liver, about 10% of patients will have a left liver less than 20% of total liver volume. 75% of patients will have a segment 2-3 that's insignificant to support liver function. So we really need to be very aggressive and have a very liberal threshold to use techniques to modify the liver volume. Obviously, preoperative portal vein embolization has been around. This is, I think, one of the earlier papers by Professor Makuchi in 1990 that demonstrated embolization of the portal vein in hilar cholangiocarcinoma, where obviously large extended resections are common. And they demonstrated the feasibility of doing this in modulating and increasing the future liver remnant volume after embolization. This really, I think, has now become widely accepted in our field and widely practiced. I think it's, and certainly I think there's a lot of literature supporting this. So does it improve outcome? Well, I think we all know the short answer is yes, it does improve outcome. And we can make operations safer by taking a patient with a small liver remnant, enlarging that liver remnant so that their risk is equivalent to someone who had an adequate liver remnant prior to intervention, without intervention. We've now come to understand this a little bit better in terms of the absolutes, and so it's not necessarily always the absolute size, but we can use this as a dynamic test of liver function. How healthy is that liver, and how does it hypertrophy after embolization? So as we move to understand the kinetics of hypertrophy a little bit better, we saw that the amount that the liver can grow is important. So this is the degree of hypertrophy, so that patients who have a degree of hypertrophy greater than 5% have significant reduced risk of complications, including liver failure and death. And again, as we understand the rate at which this happens, I think we started to understand that those patients that can achieve an adequate liver remnant volume quickly do far better than those that take much, much longer to achieve the hypertrophy. So it's not just the absolute before and after, but it's the kinetics of how all of that happens. So then really when we've looked now, some of the newer evaluations are what we call kinetic growth rate, which is the hypertrophy per week. And here you can see the sensitivity and specificity of those. And while the area under the curve is quite similar for all of these, I think using all of these together, including the kinetic growth rate, appears to be your best way of assessing this. So in our center, we actually calculate all three to make sure that all three are adequate for function. Patients who don't achieve the criteria of a KGR of 2%, degree of hypertrophy of 5%, and a future liver remnant of 30% will not proceed on to surgery. And it simply just shows us that the eye test is really not that good. And we actually saw data presented earlier from Oregon, where the ability of surgeons to guess the adequacy of the future liver remnant is actually pretty poor. And I would say even this, looking at these intraoperative photos, I would also have gotten this wrong. So here we have two patients who the first one had obviously clear cirrhosis. Everyone in the room can see that. That patient had a future liver remnant of 20%, achieved a liver volume of almost 40% after PVE, and that patient went on to have an uneventful hepatectomy with no significant liver failure. The patient on the bottom panel looks like they have a much healthier liver. They had 5% steatosis, they'd been exposed to chemotherapy, but really failed to hypertrophy after portal vein embolization. But we sort of tried not to overthink it and went on to surgery anyways, and that patient unfortunately died from liver failure. So really the eyeball test is quite poor, and I think we need to be evaluating these carefully. So we've certainly seen technical refinements in portal vein embolization, and this has been alluded to in previous talks that we can increase the hypertrophy prior to right trisectionectomy by embolizing segment 4. This is certainly, I think, not technically straightforward. I think it is quite challenging. I think many interventional radiologists struggle with this. There certainly is risk because you are instrumenting the left portal system, and we have had cases where embolic material can end up in your future liver remnant, which can be quite distressing for not only the surgeon but the patient. But certainly you can see significant improvements in hypertrophy of segments 2 and 3 with segment 4, but again, not every center will have interventional radiologists that are comfortable with this technique. We've certainly seen other refinements in portal vein embolization, particularly around the differences in embolic material. Some of the early PVE experience used larger non-spherical particles like polyvinyl alcohol. But as other techniques develop, particularly around small spherical particles like triacral microspheres, you actually see better hypertrophy. And I think the most commonly accepted explanation for this is that you're able to embolize more of the intrahepatic portal collaterals that may pass between the right and left hemilivers. We certainly were able to show this in Toronto when we changed our techniques and moving from PVA and to a glue, and saw better hypertrophy again because our interventional radiologist would create almost a cast of the right portal vein system and occlude a lot of those collaterals that may pass between segments 4 and 5 and 8. Obviously, there are limitations here. There are contraindications. Certainly, it's not something to apply with portal vascular invasion or thrombus. I think there's a lot of concerns among some people about leaving untreated tumor in the future liver remnant. I think that data is can be somewhat debated. It's obviously a concern in patients with coagulopathy, although hopefully this is not due to liver disease, or else you might be going down a difficult path. Patients with renal failure may just struggle with this, and we've seen patients who develop ascites afterwards. And certainly portal hypertension, and I don't think this has really been well studied or well defined as to what the potential cutoffs are in portal hypertension, and I was unable to find any studies, although I did look for them, looking at wedged venous gradients and the ability to undergo PVE, but certainly there are isolated experiences where patients have had variceal bleeding after PVE just because of the induction of portal hypertension. And also, importantly, you want the future liver remnant to be healthy, and so in patients with biliary obstruction, we found it extremely helpful to drain the future liver remnant to make sure that there's adequate biliary flow to optimize hypertrophy. So what happens with PVE failure? Because obviously this is the big concern. You're leaving a patient for 6 weeks to hypertrophy, and some patients won't hypertrophy because the liver's not strong enough, and I think that is the patient telling you that they probably can't tolerate the operation. But there are certainly technical failures, and obviously the concern of disease progression, because many of these operations will be done for malignant disease. When you summarize the literature, it looks about 10 to 20% of patients will actually not go on to have adequate hypertrophy, but really the vast majority of patients, 80 to 90%, are due to disease progression. But say we have a patient who really fails portal vein embolization for technical reasons. How can we rescue that patient? Well, there are some alternatives, and certainly this has been widely discussed at this meeting, that ALPS is certainly a solution for patients that either don't have access to portal vein embolization or when portal vein embolization has failed. Obviously, I think that everyone's extremely familiar with this technique, but certainly this is something that is probably better handled in a dedicated session. But how can we compare patients who undergo portal vein embolization compared to ALPS, which is a better technique? Well, again, this has been extensively debated, and certainly the direct comparisons up until recently have been limited, but certainly there is valid arguments on both sides. We now have at least some data. So we have the LIGRO trial, which looked at resectable colorectal liver metastasis with small future liver remnants, comparing an ALPS versus a 2-stage hepatectomy with portal vein embolization. You can see a higher resection rate in the ALPS group with moderate complication rates, and really no difference between the two techniques in terms of complications or mortality. There are now been variations on ALPS. So this is the Rebirth, which used portal vein embolization versus ALPS assisted with radiofrequency ablation to divide the liver rather than to physically divide it. And so really, I think these are comparative approaches, and there's been extensive, again, debates and discussions over the risks and benefits that is probably beyond the scope of this talk. There are other alternatives, though, to ALPS and portal vein embolization if your portal vein embolization doesn't achieve adequate hypertrophy. This is the MD Anderson group that obviously has probably one of the largest experiences in the West with portal vein embolization, and they took 9 patients that had inadequate hypertrophy and performed hepatic vein embolization, really showing the feasibility of this technique, and that they were able to achieve additional hypertrophy after the portal vein embolization with by taking out the hepatic vein. There's also the collaborative group analysis from the Dragon Group that compared portal vein to portal vein plus hepatic vein embolization, really showing higher degrees of hypertrophy with the combined embolization. I think the main challenge with hepatic vein embolization is the significant cost of the embolic procedure and obviously limited experience with the technique. There's other things that we can do, like this is RAPID, which is using an orthotopic liver transplant to support hypertrophy during that key period. And obviously radiation hepatectomy is probably becoming much more popular, particularly in the United States. They use yttrium-90 microspheres to really apply an ablative dose to a lobe of the liver, inducing hypertrophy of the contralateral side with the potential benefit of ipsilateral tumor treatment. The challenge with this technique is the hypertrophy is much slower. It takes about 3 to 6 months, and you can see some decline in liver function, particularly in the first 1 to 2 month range. So we'll just, I think at that point I'll conclude and look forward to the discussion at the end of the session. Thank you.
Thank you. Then we move on to the next speaker, who is Dr. McGilvray from Canada, who's going to speak about inflow modulation of portal vein pressure in small FLR.
Thanks. It's really a pleasure to be here. I don't have any real disclosures for this. I'm going to start actually very quickly with a case, and as you were saying, it's from this week. It's from Tuesday. The 66-year-old guy with metastatic colon cancer, 2 prior liver resections dating back to 2013. Came back with recurrence in segment 4B. He was planned for a resection, so he had a right PVE, which seemed to work, and then COVID hit. So when COVID hit, the referring center actually sent him for SBRT with, I'm assured, very tight fields. And then he came back. It started to grow again. So after a lot of discussion, ton of discussion, as you can imagine, we brought him to the operating room Tuesday with the plan of doing an extended right with skeletonization, because often, the very edges of this are relatively sterile, with an extended right hepatectomy, with skeletonization of the plate and the inflow to save everything we could of the segment 2, 3, and 1. It was a difficult case. Anesthesia, as it turns out, had family issues that day, so they were really bloody distracted, and the guy got like 10 liters of fluid and tons of transfusions and all the rest of it. And so there I was at the end of it. I couldn't close, staring at his liver, which is progressively swelling up more, and the portal vein is really tense. So here's the question. So he has more than 50% FLR, but he definitely has compromised function. The inflammatory response is setting in. He's had tons of fluid. So should we do portal inflow modulation? That was the question we had. And I would argue that generally speaking, in this room anyway, when we're talking about portal inflow modulation, it's in this kind of setting. It comes out at you kind of out of the blue. It's not a planned situation. It's just something you're left with. So this is really what I want to do is put portal inflow modulation in the context of posthepatectomy liver failure pathogenesis, because that's really the heart of all of this. If you're going to consider portal inflow modulation, you have to ask yourself, is it going to work in the context of everything else that's going on to lead to post-op liver failure? I'm going to talk about some of the approaches to modifying portal inflow, talk very briefly about some of the drugs you can use to deal with it, and then make some comments on alternative approaches. So here's the problem. So post-hepatitis liver failure with a small FLR, it's really not a simple problem. There are a lot of things that contribute to it. I have to say, as I was going through this and growing increasingly frustrated with this topic, I came across a great quote from a recent review from some folks who were trying to do a systematic review of this very question. And they said, well, we can't do a formal systematic review because it's just not feasible. The literature is just all over the place and too sparse. So we're going to do a pragmatic review, which is a concept I really kind of like. So I'm not going to give you a systematic review. I'm going to give you a pragmatic review. Some might say that was a cop-out, but I'm going with it, it's just what we're left with. So let's talk about pathogenesis of PHF, post-hepatitis liver failure. So the idea is that small volume causes less regeneration. So there are a whole host of things that contribute to this. Hyperperfusion, so you had a surge in sinusoidal blood flow, so you get cycle of sinusoidal dilatation, sear stress, hemorrhage, necrosis, cholestasis, impaired liver function, and inhibition of cell proliferation. That's one. Sepsis is something that we don't talk enough about because you have fewer Kupffer cells now. And actually, the liver is like a Kupffer cell bomb. 80 to 90% of your macrophages are sitting in your liver, and we don't pay enough attention to that kind of thing. So any stress you do to the liver is going to impact the immune system of the liver and of the patient. And then, of course, hepatic ischemia perfusion injuries is going to lead to local cytokine release, which is going to alter the remnant function. What are the risk factors? Well, as you might expect, they're multifactorial: patient, liver, surgery. Only one of which, of course, is portal inflow. Patient-related factors, so age, maybe over 70, diabetes probably contributes, obesity probably also, BMI over 30. Bile duct obstruction definitely contributes, although it's difficult to quantify. Steatosis also, cirrhosis for sure. Chemotherapy-associated liver injury, definitely. But this is what we're talking about. Surgery-related factors. So hypertension, massive bleeding, liver ischemia, for sure. Remnant liver versus portal hypertension. That's what we're talking about. So that leaves a small for size syndrome in live donor liver transplantation, or small for flow syndrome in post-op resections. And of course, infection and sepsis. Only one of which is portal hypertension. So there's this, but I think we would all agree that a high portal venous pressure is bad for the liver. We've all seen it, and it makes intuitive sense. This is the kind of data that underlies it. This was a trial back in 2003, where they took 79 consecutive live donor liver transplants and measured portal venous pressure over the first few days, first week actually, during the transplant and then after the transplant. And if you had a PVP, portal venous pressure, of over 20, then you clearly did worse early on. If you had a pressure over 20 later on that was over 20, you did not as badly. So the idea is that it's that early hit to the liver in the context of everything else that really sets the storm off. So lots of things contribute to post-op liver failure. Some you can modify, some you can't. Surgery, I would argue, just as the previous speaker says, you need to have precise surgery, and you need to limit the risk factors for post-liver failure. And perhaps you should consider portal inflow modulation, but we'll get to that in just 2 seconds. Something else that Sean was bringing up just now is that when we're trying to assess what is a safe limit for liver resection, it's actually pretty difficult, and probably it's a reflection of all the risk factors I've talked about. And for some patients, it's going to be worse, and some patients it's going to be better. And it's kind of hard, really, to come up with a scoring system that is going to very accurately predict the people who are going to do well and the people who aren't. You can do it in broad terms, but all of us have been caught out in specific patients. And just to point out, major hepatectomies are not all the same. So to some extent, when you're looking at this in a large series, you're comparing apples and oranges, because when you start doing different things to the liver, then you're impacting in different systems in different ways. Okay, what's my point? My point is that post-hepatectomy liver failure is very multifactorial. Pathogenesis is more of a storm than an isolated event, and it's a cycle. And there are lots of things that contribute to that. And portal inflow may be one, but it is only one. And the thing I kept thinking about when I was getting ready for this is when I was a fellow, all these many years, we were setting up the live donor program in Toronto, and I swear every second patient had small for size syndrome. Just about. They all did poorly. There was all this stress around it. Everyone was getting it. Well, flash forward 2 years, we didn't do anything differently, but all of a sudden, small for size syndrome is basically gone. And it's gone because of everything else I'm talking about, because we just got better at it. So all these small details are contributing to this. It didn't have anything to do with portal inflow. We just got better at it. Well, that's kind of why it's difficult to deal with this topic in general, because there are a lot of things that contribute. Okay. Physical modulation of portal inflow, splenic artery ligation, splenectomy, porticable shunt. Most of the data is in the live donor context, which is fair enough. This is a recent systematic review by Roberto Troisi. Went through all the papers and came up with, I think, 12, all of which are retrospective, relatively small numbers, and all of which give you an idea of what may be happening rather than a definite conclusion of what is. So let me show you sort of what they look like. Splenic artery ligation is probably the best studied. This is that paper I mentioned earlier from Ito and al. in 2003, where they measured portal venous pressure for the first week or two post-transplant. 79 patients they just measured, 7 patients they ligated a splenic artery. That's the lower line there, and you can see very clearly that portal venous pressure increases are abolished if you ligate the splenic artery. That's fair enough. You know what's interesting about this, though, is you can see actually how the portal venous pressure actually goes up after transplant. So in general, so it's a much more dynamic process than we think of it. So splenic artery ligation, again, if you have a portal venous pressure above 20, then people do poorly. The people they had splenic artery ligated did quite well. So you got the impression that splenic artery ligation or portal inflow modulation is of benefit, which it might be, but this is generally kind of the level of data that we're dealing with here. You have sort of an impression that it might work, and you have this intuitive belief that it should, but it's an impression. Splenectomy. Splenectomy is probably the second best studied, but there's not a huge amount of data. This is the most recent one I could find back in 2008. Living donor liver transplantation, 69 patients, 44 of whom had splenectomy. Again, this is a retrospective analysis. 31 of these patients, of 113 patients, developed small for size syndrome. If you looked in a subgroup and the people who had a relatively small graft, then 1150 patients developed small for size syndrome, and of those, splenectomy was an independent risk factor, or not having splenectomy was an independent risk factor. So again, there's the impression of benefit, but can you conclude that there's a benefit? Not really. Portosystemic shunt. Back when live donation was being set up, at least in North America, we had tons and tons and tons of conversations about whether we should be doing portocaval shunts routinely in live donor liver transplantation, especially for small for size. There was a lot of talk about temporary portocaval shunts. There was a lot of talk about rubber bands that you could remove post-op. I'm not sure it really ever went very far. This is a paper by Roberto Troisi again from AJT in 2008. 13 patients with small grafts with a graft recipient rate of less than 0.8, which is relatively small. They did a shunt in, let's say, 8 with no small for size syndrome. They didn't in 5, and they wind up with small for size syndrome. So pharmacological modulation. Somatostatin is the one that we all talk about. Probably quite a few of us use somatostatin post-op. The data for that is relatively sparse. This is Rahim, that's right. Actually, a response to the review that I brought up earlier in 2021. If you use somatostatin intraoperatively, you can clearly drop the portal venous pressure. And to some extent, it's predictive. If it drops substantially, then you're less likely to have posthepatectomy liver failure. If it doesn't drop, then you're more likely to have posthepatectomy liver failure. So you can drop the pressure. It does seem to be predictive. Is it therapeutic? I don't think we know. So alternatives. I'm just going to go back here. Alternatives. So I think really the bottom line is, what do you want to do here? You want to stimulate liver regeneration. You want to stimulate liver hypertrophy. But I'm going to make the point that for the human liver, we don't really understand it all that well. I mean, the fact that 80% of our macrophages are sitting in the liver, and that most of us probably didn't know that until I said that, is an indication of how poorly we understand the human liver. But there are some really cool new technologies that are coming online that are going to change all that. Single-cell RNA sequencing, for instance, single-nuke RNA sequencing, the nanoparticle drives, they're all there, and they're really revolutionizing how we're looking at the human liver. So I think in the near future, we're going to have some new things that are come out that are actually going to be able to explain what human liver regeneration is, and that will lead to real therapies for posthepatectomy liver failure. So my guy, so here my poor guy with the swollen liver and the irradiated field and all the rest of it. So we talked about doing portal inflow modulation, but we did kind of do that. In the end, we just left him open, which is an alternative I don't think we talk enough about. Just put a big vac dressing on, left him open, dried him out for 2 days, and then closed him. And his bilirubin, thank God, is dropping. So conclusion. So portal inflow modulation is only one aspect of a very multifactorial problem. So optimizing liver for resection is a combination of preoperative, intraoperative, and postoperative planning. I think if you take a step back, inflow modulation probably does shave the odds for improved liver function post-live donor liver transplantation or resection, but it's shading the odds. It's not really driving a result. If you do consider it, then I reach for splenocardial ligation first. I think it's the safest. Pharmacological modulation is a possibility, but I think it needs more study. And I think really what this is screaming for is more trials, and I think really a better understanding of what the entity is, posthepatectomy liver failure, and of what human liver regeneration is. Thanks.
Well, the last speaker is Dr. Daniel Malouf. He works in Maryland, but he's from Argentina. Specifically for the best region of Argentina is Córdoba. He talked about medical management of postoperative liver failure. Dr. Malouf.
Good morning. I want to thank the organizing committee for this opportunity to present here. The ISLGLS, or the International Study Group for Liver Disease, defined posthepatectomy liver failure in the consensus of 2011 as a post-operative acquired deterioration in the ability of the liver to maintain the synthetic function, the excretory function, and the detox function, characterized by the increase of the INR and hyperbilirubinemia, divided in severity based on grade A, B, and C, C being the most severe with the perioperative mortality of 54%, grade 8 with the perioperative mortality low, and B in between. The pathophysiology essentially revolved around the disruption of the normal liver hemostasis and detox function, as well as the hepatocyte regeneration capacity that the liver has, and in most severe cases, developing of multi-organ system failure and patient death. Prompt identification and diagnosis, as well as support of the liver, are areas of paramount importance for any hepatic surgeon that do hepatobiliary surgery and form the cornerstone of the management. Here we describe different alternatives of medical therapy, including medical standard of care, extracorporeal liver assist devices, and cell transplantation. I also add the liver transplantation, as I truly believe that is a very valuable option for those patients. And there is also several innovative approaches, such as stem cell, mesenchymal cell, and organ bioengineering that are quickly developing. The principles of managing medical management for post-hepatectomy liver failure follow similar protocols that any ICU management for acute liver failure. The treatment essentially focus in early recognition of the event and goal-directed resuscitation in the ICU, avoiding any complication related to infection or vascular complication, and preventing malnutrition. The therapeutic goal is to keep stability in terms of cardiovascular and respiratory function, as well as the kidney function, and good nutrition with at least 2,000 calories a day. Sometimes liver biopsy may be necessary when there is intrahepatic cholestasis, which is associated with high mortality. In terms of extracorporeal liver support system, include artificial, which use albumin as a scavenger molecule to assist liver detox. This is also sometimes called liver dialysis. The devices can temporarily or unsuccessfully detox the bloodstream and serve as a bridge for either recovery or transplantation. The most common use devices are molecular absorbent recirculatory system, or MARS, single pass albumin dialysis, or SPAD, fractionated plasma separation and absorption system, or Prometheus, selective plasma filtration therapy, or CPED, and hemodiafiltration that is mainly used in Japan. The MARS mechanism is based on the concentration gradient using albumin as a scavenger. The patient plasma toxin are distributed in the internal membrane of the system on the surface and get in contact with the dialyzed side that basically extract all these or remove all these toxins. The toxins mostly is metabolites, cytokines, the good and the bad, and nitric oxide, but also remove growth factors and vitamins and other things that are tried to be preserved. Initially started in the late 90s, when the first report had been extensively used for the treatment of several different type of acute liver failure. Some of the advantage that is well tolerated, that has clinical benefit in terms of encephalopathy, hemodynamic parameters, and survival, even when still questionable. The disadvantage is that it's expensive technique, is not widely available, and one of the side effects is low platelets. Because it's usually used during emergency and for all kind of acute liver failure, it's difficult to studies to compare. However, this review from the group from Trandon and Froggy compared the 4 technologies and was recently reported in the Gastroenterology and Hepatology Journal. Now, keep in mind that in some countries, these systems are still not approved, so regular plasmapheresis is used frequently, kind of replace this. The aim of this review was to compare existing data on efficiency of this device. The outcomes were measured using overall survival through the study period. Survival for patients that were given MARS was 42%, and for SPAD was 41.6%. Basically, identified that was a little bit improvement in survival in those that underwent to MARS. Also, the group in Vienna make this comparison between the single class albumin dialysis or SPAD versus MARS, published in 2016. The aim of study was to compare 2 devices and was a prospective RTC study designed with particular focus on reduction of bilirubin levels as a primary endpoint and influencing clinical parameters as a secondary endpoint associated with acute liver failure. 32 patients were involved, and both systems significantly reduced plasma bilirubin. However, bile acid, creatinine, and urea were reduced more in MARS. In our University of Maryland, we have more experience with MARS also because it's shock trauma center, we have available MARS and we use it frequently. This study recently in 2017 was reported for use of MARS for 27 patients with acute liver failure. As you can see, there's 5 patients with severe liver trauma, 13 patients with bridge transplantation, and 9 patients that acute liver failure of idiopathic cause. In terms of result, it was a retrospective study, but shows 60% survival for those with severe liver trauma. For those patients that was bridged to transplantation, 9 of them received a transplant and had a good survival of 1 year, close to 80%, and 4 that didn't receive transplant died. And in terms of acute liver failure for different etiologies, 67% survival at 1 year. So the conclusion was that MARS therapy successfully replaced hepatic function with acute liver failure, allowing time for spontaneous recovery or transplantation. Getting into the video, artificial livers is a system relying on the use of cells, hepatocytes that can be human or not human, to perform detox and secretion of liver synthesized factors. The selection of the ideal cell source and the design of the most sophisticated bioreactor is the main issue of challenge. Primary use hepatocytes appear to be the most appropriate cells for the use of bulks, availability, and of function when culture ex vivo also is limited. The first bioartificial system was developed in 2001 by Matsumara. The essential comprised a hepatocyte within the reactor with the matrix composed by collagen. And since then, several devices have been developed to treat primary acute liver failure. In theory, this system should be much successful than the liver dialysis, as provide metabolic function due to alive cells. This is some of the studies that have been reported. As you can see, there is different systems, specifically 4, the ELAD, the bioartificial liver support system, the MELS, which is modular extracorporeal liver supports, and the AMC Academic Medical Center Bioartificial Liver. You can see that the type of studies is very variable in terms of treatments, sessions in clinical phase, and the number of patients. In general, all of them show that the improvement in the encephalopathy, improvement in biochemistry parameters, and some study has shown also improvement in the survival. This is the first prospective randomized control trial reported back in 2004. We're using extracorporeal liver support system, where the metro developed this RTC and studied 171 patients. 85 underwent Chupal treatment and 86 under control. The 30-day survival for those patients was 71 or 62, which is technically non-significant because they include patients with primary non-functional post-liver transplant. When they were excluded, the survival for the bile group improved. So the conclusion was survival for fulminant and subfulminant hepatic failure patients was significantly higher in patients that received bile compared with the control group. The ELAT trial was published in 2018 by Thompson. This was used for severe alcoholic hepatitis resulting in acute and chronic liver failure. It was a multinational prospective RTC, studied 107 patients with standard of care versus 96 with the ELAT system. Unfortunately, didn't show any survival benefit. A potential alternative for transplantation is allogenic hepatocyte transplantation. Over the last few decades, we've seen a lot of research and improvement from the bench to the bedside. Standardized technique has been established with isolation, culture, and cryopreservation of human hepatocytes. Clinical hepatocyte transplantation safely and short-term efficacy has been proven. However, there's still major hurdles in the field. Mainly concerning to shortage of cells, low cell engraftment, and lack of long-lasting effect continue to be a challenge for the application widely in the clinical setting. Some of the advantages, hepatocyte transplantation is less invasive, less expensive than orthotopic liver, can be performed repetitively and several times. Cryopreserved cells are in the freezer, so can be used whenever it's needed. Native liver remains, so you can treat the patient more than one time, and you can use livers where the source of cells for transplanting more than one patient too. Some study has shown some benefit in treatment of acute liver failure. The cell number estimated to support liver function is about 10 to 15% of the total liver mass. Cell transplantation also through the portal system is not always possible. So other options or other alternative have been published like intraperitoneal or intrasplenic. And overall, this study has shown that there is some improvement in the function of patient has fulminant liver failure using hepatocyte transplantations. And the publication mainly in the 90s and until now. So it is a good future for this technology. And I will highlight the fact that liver transplantation continues to be an excellent option. A recent paper published by the Northern European group was a multi-center core study. As you can see, 10 patients received transplant in 12 years, so very rare. Obviously, there is some ethical considerations, and due to the organ scarcities, this is the big challenge. However, the outcomes are excellent. Patients that have no cancer or the age allowed, they can get transplant, and they do very, very well. So this is another issue to keep in mind. So to conclude, PHLF is a rare event but may carry high mortality. Best way to treat is to prevent. Medical support is universally accepted and is successful. Artificial and bioartificial liver support seem to be effective, especially for the short term, allowing the liver to regenerate or bridge for transplantation. However, it's expensive and not widely available. Hepatocyte transplantation has progressed significantly, but still not on prime time. And liver transplantation is always an alternative for this type of patient. I want to thank again the organizing committee and thank you for this invitation.
Well, thank you very much, Dr. Malouf. We had some excellent presentations this afternoon, and there's now time for discussion. So I suggest we do that in a structured manner and start with the case presentation presented by Dr. Esmond. Maybe I can kick off with the first question about your case, a dramatic case, of course, and very unfortunate that on the first possible day, the liver vein got twisted, and therefore you had to reoperate the patient. And I think if you have a marginal liver and something like that happens, a major complication, then that has a major impact too, and sometimes very difficult to overcome. So my first question is, do you always take down the triangular ligament? Because that prevents the torsion and is also very helpful if you have vascular problem, that it acts as a vascular pedicle. So please, your comments.
Yeah, so usually we mobilize as little as possible. So we would try to save it if it's to
But
keep
not
it
in this
stable.
case, apparently.
Well, apparently not.
No. Are there any questions regarding the case?
Question and a comment.
Yeah.
Sky Mail from Oregon. Dr. Fretland, thank you for sharing your experience. I think it's something that we all see and worry about, and highlights the importance of the really critical post-operative management for these patients. With our trainees, we communicate that liver operation is the easy part. It's actually getting them through and intervening at the appropriate times in the post-operative period in that first 48 hours that's going to make or break this patient's recovery. That being said, what should we do as a society and as a specialty in standardizing the post-operative care for these patients? Should your patient have been in an ICU where they should have been actually monitored very closely? Because you get one chance to get this right.
Yeah, I mean, I think very often when we have a patient death, there's a series of mistakes. And the patient was in our good recovery unit, and they usually would catch this. They just didn't understand this phenomenon when he was over on the right side and he got hypotensive. And the second, and our primary resident didn't get it either, didn't really connect that to the liver. And the second mistake was that they didn't realize that the transaminases were so high and that the lactate didn't turn. So I mean, normally we would have caught that and done the CT at midnight instead of at 6 o'clock, and then I think maybe we could have saved him. So, but yeah, should we have some very really easy danger signals, some red flags for our patients to try to prevent them? That would be a good idea for sure, also for the trainees.
I just sort of double down on that. I'm not sure it's the monitors and the bells and whistles that are attached to the patient that are going to make the difference, like, in terms of standardizing their care. It's the person watching those numbers, and if they know that, the awareness that something's not right is the key thing. And so I personally don't think, having them, even if you had a Swan-Ganz catheter and the patient fully intubated, unless someone knows to act on that information. There's a lot of ICUs where they probably would just manage the hypotension by escalating doses of pressors, and that's we're all shaking. I see lots of heads shaking because everyone has the same experience.
Any other questions? Well, I think, yes.
Over there.
Thank you, Asmund, for the case presentation. I have something that I did not get, because when you bring back the patient to the OR, after a few days after that, the patient went well. And then suddenly bilirubin starts going up, as far as I remember. So did you look for any portal vein thrombosis or hepatic vein thrombosis?
Yeah, there was no... so the reoperation was really on the morning, the first post-operative day, and then after that there was no more surgeries. We really considered to stent the hepatic vein. There was no thrombus, but it was a little bit narrowed because it still wasn't quite stable. But we didn't, our IRs didn't find indication to do that because the ultrasound seemed okay. So I think we also considered to embolize the splenic artery, but I don't think we did that in that case.
Yes, I think that most important thing is to exclude vascular problems, complications, when you suspect a problem, and of course you start with the Doppler, and then probably CT scan has to follow. But I think when you look at the pictures of liver failure, there are two types. There are the ones which fall into liver failure and they just, nobody can stop them. And you have the ones who very slowly progress and they die on the hepatology ward. And that's why I think that you should always look at a 90-day mortality and not a 30-day mortality, because they die, the slow ones, they die in another ward. They would die not on the surgical ward, but they would slowly go to the hepatologist and they would try to figure out how to help them. So that's just a picture we know it can occur.
In this case, it's like a pseudo-Chiari syndrome.
Yes, but that was, of course, because of the early intervention, it was reversed.
Yes.
So it was a short moment. Any other questions? Okay, so Then we move on to thank you. Presentation of Dr. Sudeep. Any questions about that? So he was talking about the tools we have for assessing the volume and function of liver volume. Professor Pitt.
Dr. Pitt?
Yeah, Henry Pitt. You know, we talked about a lot of very sophisticated things, but something that we studied recently and published in Journal of the American College of Surgeons was just the albumin bilirubin score. Very simple. You know, you can do it on your phone. It's a pretty darn good predictor of post-hepatectomy liver failure. Do people use it? And if, you know, as sort of a first screen as to whether you want to do more sophisticated things? That's the first question.
That's for Mr. Sudeep.
Yes, so it was there in one of my slides, and Professor Pitt, we read that with great interest. So like MELD, like Childs, which are very crude, the ALB and the platelet ratio are good screening tools, but then that will give you a population where you really need to look further. So you're absolutely right, but it's just a screening tool.
But it shows simple. I think we should use it more.
Absolutely.
Yes, but of course the whole assessment is quite simple. But you look at correlation factors and you look at bilirubin, and in the old Puke score we had also the albumin, but in the MELD we don't use it anymore. So I mean it's all about a few parameters we can use clinically, but that's not enough, I think.
Yeah, I mean, the analysis we did suggested that albumin bilirubin was better than MELD or MELD sodium.
Yeah. Yes, Professor Lesutel.
Thank you. A question about MRI. MRI may be a very interesting examination, all-in-one examination, because we can see the tumor relationship with anatomic structure, volumetry, steatotic ratio. But what about the function, the assessment of the function with the liver-specific agent? We heard about that since now for 10 years, but nothing come out. Do you have some insight about that?
So that's an excellent question. So the problem that you would face is that if you're looking at MR spectroscopy, it's only looking at a point within the liver. What we need is a combination of an area of the liver where every point has to be studied. And I think as computational software improves, there are many of these studies which are ongoing, and the Hepatica is an example which I showed you, where all this will be put together and we'll have an answer in the near future. But I think today we are very far away from saying that we can use, special contrast agents or a special type of spectroscopy to really tell us that the MR is good enough to predict function within, a segment of the liver.
I think
we are getting there, but it's the future.
But I think MR spectroscopy is a different thing than using MR with a liver-specific agent to actually measure the function. So I agree with MR spectroscopy, you're looking at one point, but it is the use of the MRI using hepatocellular specific agent,
yes,
which you can monitor the uptake and the elimination. I think that's what Dr. Lesutel
yes, so again, Gabixate behaves similar to mebrofenin, but again we have the same limitations. Yes.
Yeah, the limitation is, I think, on the side of the radiologist, because it's a very difficult technique, and we would dream of a one-stop shop, having a diagnostic MRI with a follow-up in the same session with a functional assessment, but that seems very far away. I mean, we've seen that for many years now, trying to evolve in a clinical useful tool, but it didn't happen yet.
If I could add, actually, we looked at that with EOVist or PrimoVist, depending on what region of the world you're in. And our data, we didn't publish it because it didn't achieve I thought it was valuable, and I think everyone in this room thought it was valuable, but clearly the reviewers wanted a better p-value. There are some issues with it, though, however. that the timing has to be very consistent in the studies. Even small, like minute-to-minute variations can be different. There are some livers where there can be differential enhancement with those hepatocyte agents, and again, but I think if we go back and look at it with better power, maybe we'll get that p-value that reviewer was looking for. I would add the other one technique that we actually will be publishing on, or it has been accepted, but it'll come out soon, is MR elastography in assessing the degree of fibrosis of the liver quite accurately. So.
Then there's a question by Dr. Erdman from Amsterdam.
Yes, Joris Erdman from Amsterdam. We've been working a lot with scintigraphy and trying to pioneer with MRI. But I think I want to comment on the previous remarks. It's an intrinsic problem with MRI. The standardization or normalization of the MRI signal is just impossible, because every person, when you lie in an MRI, you influence the field. And if, like 2 blocks away, a truck with a steel a load of steel beams drives by, the field is also influenced. So it's such a complex technique, and there are so many really simple techniques available, like scintigraphy or ICG combined with volumetrics or LIMEX. LIMEX is also quite complicated, but I think maybe we're looking to design a new Lamborghini, which is too expensive. No one knows how to drive it, but we already have like a Ford Focus in our garage that works really fine. So maybe consider that.
Great. Any other questions for?
So what do you think about scintigraphy risk reported by Santibanez and collaborators to access the liver remnant, especially in the second time of ALPS, but you can apply it, in this case, in extensive liver resection?
In the problem, ALPS is a very specific situation where you get rapid growth, and then you can very clearly see the difference, and you can see that there's very good uptake. The problem with keeping a functioning liver in situ is that, again, you get a little global uptake, and if you focus using SPECT, sometimes you have problems because of the biliary excretion within, and areas where the bile duct is rapidly excreting dilutes the whole picture. So there is a difference between doing SPECT preoperatively before resection and doing it something in ALPS where you have a part of the liver which is ischemic and damaged and a part which is beautifully functioning, and you can demonstrate the difference between the two. So I don't know whether that answers the question. So it's very good in the latter.
Now, the problem with functional studies in ALPS is that when you measure function, you actually have a real value of the capacity of the liver, whereas if you do only volumetric assessment, then you see an increase in volume, which is not because of the cellular proliferation, but because of the cellular swelling which takes place in the first days. So it gives an overestimation of function when you only look at volume. I think that's a crucial point when using these techniques when you've done the first stage of ALPS.
One point is volume, and other point is function.
Okay, so then we move on to the next speaker, Dr. Cleary. Are there any questions about his presentation? Showing us all the tools we can have and we can use when we suspect a small liver. Yes, Henry.
Henry Pitt again. Something that I don't think anybody mentioned was the small trials of perioperative steroids, and then the recent trial from Canada that Chad Bold published in Annals of Surgery with bigger numbers, and we're hoping actually to emulate that trial on the NISQUIP platform going forward, so it's not just a couple of institutions, but many institutions. But the question is, do we believe that? Do we think perioperative steroids can you know, impact the inflammatory part of all the things that are going on, and in the end, you know, maybe have better regeneration and have less liver failure. What are your thoughts?
No, I know. So, you know, I think that there is that interesting data. That's certainly why Chad did the study. I think we, you know, and they're to be congratulated for doing a prospective interventional trial in liver resection patients, which, as we all know, is not easy. And so I think it's data that we have to pay attention to. I'm a little bit uncertain of the mechanism. I'm a little bit uncertain of the, you know, that we maybe as we roll it out into larger studies that we may see secondary complications of high-dose steroid intervention, but it's certainly, it's a great effort by Chad to do that and a tremendous contribution.
Question, microphone 2.
Yes, thanks for your presentation. I'm Jens Smits from Maastricht University. It has been described that portal vein embolization can cause tumor progression in the future liver. And what do you think about continuation of chemotherapy during or after portal vein embolization?
So there is data about that. I believe, again, fact checkers may prove me wrong, but I believe it was Memorial published data of continuing cytotoxic chemotherapy during the hypertrophy period. So standard chemotherapy, I believe most of their series was FOLFOX and FOLFIRI. The main thing is I think there's fairly good, widely accepted evidence that holding a VEGF inhibitor like bevacizumab or a VEGF antagonist during that period is probably important. So you need that, and again, this has been widely discussed, hold that VEGF agent in the last cycle of chemotherapy, give that 4 to 6 week washout based on the half-life of the agent prior to portal vein embolization. But yes, many patients can get at least one cycle of cytotoxic chemotherapy during that time. In terms of the progression of the future liver remnant, you know, there's a lot of hypotheses around growth factors, et cetera. I think it's been very difficult to tease that out between just overall progression on both sides of the liver, including the embolized side. Because as I said, you know, most of the patients that undergo portal vein embolization but then don't get to surgery is for disease progression. So whether it's in the ipsilateral liver, the contralateral liver, or elsewhere is indeterminate. These are all, you know, as we all know, aggressive resections in high-risk patients.
Thank you.
Okay, thank you.
One more question.
Yeah, Bobby Dasari from Birmingham, UK. A comment and then a question. Comment is that with the dual vein embolization, we're seeing a 20% increase in the growth and almost double that of the growth in the function, almost a 40% to the previous question. So, and the second question is, if we are talking about further studies, whether it is steroids or splenic artery ligation, what should be our measure of outcome? Because PHLFC, if we look, most of the series, it's about 3 to 4%. We won't have many patients standardized for a surgery with the background liver to have a measure of outcome of such a low incidence. What should we be measuring? Is it realistic to measure PHLFC?
Yeah, I mean, I think one of the things that's really been good is the actual, you know, definition of postoperative liver dysfunction and biochemically measuring that. Unfortunately, true, you know, grade 3 liver dysfunction is uncommon, but there's a direct correlation between rates of A, B, and C dysfunction and death. So yes, we probably would benefit from others, but again, those studies are difficult, but we've at least better off than we have been with a standardized definition of liver dysfunction.
Thank you. We have to move on now to the next presentation. Are there any questions for Dr. McGilvray? You talked about portal vein pressure modulation.
Clear as mud.
Well, the question that came up when I followed your presentation is, do you think that portal vein embolization as a preoperative strategy is also advantageous in terms of preventing increased portal pressure after the resection? Because what you actually do is embolize the portal system to the right side a few weeks before you do the resection, And instead of an acute increase in portal pressure, what you have when you do a resection, now you modulate that because you've done your portal vein embolization, you've closed the system. So what do you think about that?
Well, I mean, I think that makes a great deal of sense. It probably does. But, you know, it's interesting, as you were saying that, you know, when we talk about portal modulation in general, I mean, it requires some sort of baseline measurement of it, really. And since none of us really do that, it's hard. I mean, we're all kind of speculating about what is going on. It makes complete sense. I suspect it does, but.
Okay. Any other comments?
What do you think about a negative immunological effect of splenectomy to reduce portal vein flow?
So that's a really interesting question. So you're saying, what do I think about the long-term immune consequences or the short-term immune consequences of taking out the spleen? Short-term then? Sure. Yeah, I don't know. I mean, you know, I've never been all that impressed with, you know, OPSS, overwhelming post-splenectomy syndrome, or any of the rest of that, because, you know, really, when you look at what, the liver is such an impressive immune organ already that it very quickly takes over the splenic function. So, and, you know, I've never really been all that concerned, even in my splenectomy patients, about an acute change in the immune system. So I'm not aware of anything really that would make me worry too much about that anyway.
And another question, you use nutritional risk violation after liver resection?
Nutritional risk. Yeah, we should. We're starting a prehab study for exactly that reason, but we haven't done it routinely. But absolutely, we should be.
A very short question, please, because we only have a few minutes left, and we have one discussion still.
Small for flow issues and use of octreotide. I mean, I've had anecdotally used it post-operative cases with rising bilirubin earlier on, and they seem to have some effect. But do you know whether there's a trial going on or there is a clinical evidence for that?
I'm sorry, I missed the intervention. It was
octreotide.
Oh, octreotide. Yeah, I mean, we probably you have the same sort of experience that we do. That we put octreotide on, and we have a sense that it will work. And you know, before that, it was N-acetylcysteine and you know, Mucomist, and you know, I'm not convinced personally. I think it probably does lead to a small drop in portal pressure, or whether that's actually significant or it has any long-term effect, I don't know. And no, I'm not aware of any trials for that.
Okay, thank you. We have a few minutes left for the discussion of the last presentation. Are there any questions for Dr. Malouf about liver assist devices? Do you think that we should further, let's say, pursue the use of liver assist devices post-resection in a different strategy? The problem with liver assist devices is that they're used when you're already too late, when the patient is already, let's say, having clinical symptoms of liver failure, whereas it might be better if you could use them just from the start, because what happens is when the liver gets loaded by the toxic effects of a liver which is nearly failing, then it will only get worse. So you have to prevent that, or you have to proceed with decreasing the toxic load immediately with using a liver assist device. Do you think that would be a better strategy?
Yeah, well, that's an excellent topic.
We didn't hear you.
Can you hear me?
Yeah, better.
Okay, sorry about that. So let me get closer. So what I was saying.
Oh, it's not. Yeah, it's.
Okay.
I'm sorry.
I don't know.
Sorry, we can't hear you.
Hello.
Yeah.
Can you hear me now?
Yeah. Well, I think we have to close the session because we have full. Yeah. Thank you very much, all speakers and the audience.